I'm going to start with just a pulse survey. So I know there's a lot of InterSystems customers and partners here. So just a show of hands first, if you're involved in a digital transformation project, whether coming from paper or just doing a digital, put your hands up. Great. Okay, now put your hands down leave them up, so put your hands down if you are doing a pure paper to digital transformation. Oh, there's a few. I saw about 4 or 5 hands go down. That's where we are at the moment. Now, is anybody doing an upgrade of Trak? Oh, there we go. Excellent. So hopefully, some of what I'm going to talk to you about today is useful. So look, my name's Ken Leong. I'm the Senior Project Manager at for the Southwest Alliance of Rural Health. Currently doing a bit of a major project for the region called the Trak Edition upgrade. You'll see that I'll use the term SWAR a lot, the Southwest Alliance of Rural Health. I'll explain that in a minute. But yeah, so I'm hoping that today what I'm going to share with you is just some of the how. You've heard a lot of the whys from EMC, from New Zealand, from Acacia and the Northern Territory project. I'm going to show you a bit about the how. So I'm a project manager, and before you judge me, I question my own life choices as well. So let's go. So Southwest Alliance Rural Health. It's been around a while. It's been around since 1997. Currently, we've got 14 health services in this alliance. They're all members. If you want to look at from a geographical standpoint, if you look about from Melbourne to the South Australian border, that's about 350 k's. Cut that 50 k's out from Geelong. If you draw a vertical line from Geelong all the way to the South Australian border and go south, that is the region that we look after. There's about 430,000 odd customers, patients in this space. And SWAR itself is interesting. This is the core services that SWAR present themselves as. Now, there's a problem with that. The problem is that you don't see much clinical capability in that space. So this is one of the things that now in the past 12 to 18 months I've seen start to change. The bringing in appointment of a CCIO and those sort of clinical leadership roles and clinical capability. What I'm impressed with, though, is that over the years that we've seen Trak implemented in this region, we have seen the product grow. So it's been organic, but it's never been quite recognised, I think, at this level. So I don't want to I am starting with a bit of a challenge, but my legacy on this project will be to try and actually establish that BAU and improve that capability moving forward and justify that. So we've had Trak for 20 odd years, guys. Trak was first implemented in 2005. There are people in the audience here that have been involved since that time as well. We currently use Trak for patient administration, our PAS, clinicals, ED, operating theatres and community. And yes, it is very much a holistic EMR for us. Again, looking at the actual geographic location of this, we've basically we have 4 main hubs, but we've got 17 odd sites and 11 health services. Now, what's interesting here is that Barwon Health, who is our lead agency, is actually not part of this. They don't use Trak, but everywhere to the west of that, so everywhere west of Geelong through, we have Trak there, and you can be a patient in any one of those regions, and you'll basically be able to pull up your record in Trak. It's pretty good like that. We are on 2018 version, so we are on a 7-year-old version of Trak, and hence why my team is here, and we've assembled to really uplift that and move to the next generation there. 4,500 users, so it's not huge. You've seen Acacia; they've got double that, but we have our own challenges in this space. So what is this project? This project is really moving from a bespoke version of Trak. So when we implemented Trak in 2005, it gave us the opportunity to really build out screens, build out heaps of functionality. And that's great. That really accelerates your ability to deliver clinical capability to your patients. But it is also a bit of a trap. And come to 2018, that was the last time we took a big upgrade. And now we've got Edition. We need to move to Edition. We've got to somehow convert all of the bespoke work and move that into the Edition. And there is change involved in that. So I'm not leading a technical project at all. I'm in the stage where I've got 26 people on my little project. 2 of them are technical. All the rest are clinically trained or clinicians, or they're functional configuration experts, or they're change and training people. So when we get to this point, we're not talking about tech anymore. We're actually talking about the change and the people. So that's huge for us. again, this project itself, just to do an upgrade, and I know New Zealand, I know we've heard the challenges that we face similar. It's been a long run, and by the time you do get your business case sorted, statement of work done, yeah, you may be chasing your tail on a few other things. So, and so what we've got here is we've got two phases in our project. We've got a big platform upgrade. We've got electronic medication management in phase 2, as well as maternity modules. So EMM is going to be the big one. EMM is going to be the kicker, but we've got to get the platform upgraded first. EMM, we're going from paper to digital. That's pervasive across all craft groups and the whole health service, including your patient administration side. So, we've got our path mapped out for us here. So this is phase 1. So I'm a project manager, so it's always the 101 stuff that works for me, and I've been doing that for 25 years. So I'm not inventing agile project management here. I'm not going to introduce that concept. That's for software development for me. I'm just going through the SDLC life cycle. So we're at that point where we're actually doing internal testing at the moment, and next year we'll be doing user acceptance testing, training, and going live. Things that we're going to put in there, and you'll learn a bit about some of these techniques that we're doing, is that we're also doing a shadow charting exercise where we actually have our team shadowing real clinicians on the floor, doing what they're doing today in Trak 2018, in Trak Edition, and really understanding how they use the product and how they will be using the product post go live. So that's just phase 1. We've got, EMM. That's not the scope. I'm not going to be talking too much about that today. But we have tons of challenges. Firstly, we've got 20 years of customized functionality. So there's going to be winners and losers in that. And there are people there's going to be people that are, there's going to be perceived and actual loss of functionality, but it's also about different ways of working. And this is why my project is all about change. That's all it is. It's change management 101. We also have a big bang go live strategy. So when you get to this point, you can't do stage rollouts. You've got Trak in 17 sites, and you can't just say, I'm going to run one or two sites on a new version of Trak and expect that the old version of Trak, there's going to be data integrity and you're going to be able to go to a different hospital and see your patient record in the same way. We've got a big bang. We have to do big bang. We've got 7 years worth of to catch up to do, get from 2018 to today. And we do have a complex ecosystem. Look, this is probably not, I don't want you to study that, but basically the yellow box there is Trak and everything else connects to it. So basically, yes, if I screw up the upgrade, I screw up a lot of things. But yeah, look, so basically there's a big ecosystem behind all this. And we do need to be very, prudent about how we go about the upgrade. I want to touch more on this SWAR Alliance though. This is unique. I come from South Australia, so everything is very top down. The governance is fairly straightforward. Alliances, you don't get that. You basically have health services. I've got 11 of them I have to deal with that all operate their own governance. They all have their own decision making. They have policies, and we did a policy review, 1,400 policies across the region, a lot of duplication, and you can imagine trying to then align everybody because they're using the same platform. Why the hell do we have that many policies? Good question. We've got to try and review. We've got to try and go and only recommend that these health services actually go and review it and align it. We can provide them some baseline stuff, but it will be up to the health services to really pull their policies together. That's quite an interesting one there. We also struggle with very Trak Care adoption. Our demographic of users goes from those that have been in the system, and we're talking regional people here that have been there for 40, 50 years, probably on the edge of retirement, and they're saying, we're hearing things like, when we go to Trak, we're going to retire. So it's like, holy crap, like what happens there? That was not the intent of this project. And then we've got a lot, and being regional, we've got a lot of locums coming through. We've got a lot of float in, float out, people that are working for 6 months, 3 months, and we need to cater for that spectrum of users. And I'm sure people in Northern Territory, same thing. We've got varied sizes of health services. So we have some that operate 24/7, some with acute, some with community, some with both. And we just need to manage how we train these people up with the new Trak Edition coming through. And regional and rural workforce considerations. I mean, I've just touched on a bit of that before. They're geographically dispersed. There's capacity pressures, always, frontline priorities always come first. So how do we put in a brand new system at the same time as they needing to support the front line? So we've heard that through some of the previous presentations as well, those sort of challenges. We've got very digital literacy too. And when you do your training needs analysis, you work out that some sites are still using paper and they might be using other means to get information in Trak just to cover statutory reporting, but it's not the way the whole system was intended to be used. So we uncover that. We're starting to get a really good picture of how we're going to try and bring everybody to that competency and get the digital literacy a bit more leveled. But we can't do that as a project alone. We need our health services to do that. So I'll talk a bit about the engagement coming up too. And lastly, we'll get moving to edition. So every 2 months, there's a new release. There's brand new features coming through. We've got to keep up with that. But on top of that, we've got our own requirements that get pushed into these releases. So we've got to test those and make sure the product's stable enough. And we've gone through 5 rounds of internal testing so far. Hopefully this is the last one before we go to UAT, but no promises. We need to make sure that we get a safe product out there for our end users there. I'll talk a bit about governance too. Now this is a bit boring, I know. But what's interesting about the SPIRE Alliance here is that we've got Barwon Health at the top of this, but Barwon don't use Trak. So we actually are sort of in that world where we have to justify a lot of what we're doing with Trak. I'm not going to talk too much about the politics around that. I'm going to talk to you a bit about how we run our project itself. So we have 3 basic levels of governance in our project. We have a project control board. That's attended by the 11 CEOs of all the health services. We have a project steering committee. Everybody knows what a steerco does, but at the end of the day, we've got representatives across all our craft groups, and they're empowered to talk on behalf of their craft group for the whole region. You have to put parameters around it. If I said we've got 7 craft groups that we know of. If I said that 11 health services were to put a representation in for each one of those, you'd have 77 on your steer code. That's not workable. So we've got parameters around that. We've got strong terms of references around both that, the project steer code, and we have clinical working groups. And clinical working groups, that's where the magic happens. So, I mean, basically, just to put it into a nutshell, you've got the project control board doing your scope, budget, and schedule. Got your steerco looking at clinical best practice, clinical standards, and the project risk and issues. And at the clinical working group level, we're looking at workflows. We're looking at clinical process guidance. When we look at configuration and making decisions around that, we have these CWGs making helping us make those decisions. I'll double click on that clinical working group for a bit because we do have a clinical decision framework, and this might be handy as a concept. I'm a simple bloke. I like to keep things very simple. So for us, when we have a lot of decisions to make, our team need to come across new functionality all the time with Trak. We're still learning about the product today. And some of those changes in Trak are significant, what we call significant changes. They're a significant deviation from what the user might do today, or they're brand new. So we start lining all those up. And as a project, we're empowered to make decisions on some of them, but some of them we can't. So we need to present that to our clinical working groups. So what we do is we look at the options, we analyse those, and we present them. And we only present the ones that a decision with significant impact to health services. If you present every single clinical decision that needs to be made, you'll never get your project delivered. So the project needs to be empowered by those project steering committees and project control boards to be able to make some decisions on it. But you do need to put parameters around what is a significant change for the network and do it that way. Now, we look at it from 3 ways. You've obviously got clinical risk at the top. You might be looking at a track care option, or you might be looking at a change in workflow. Look at your clinical risks. We look at does it meet stat requirements, and we also look at workflow impacts. This prevents that whole, I want this feature or I don't want this feature, and it puts a bit more objectiveness around those that you find in the user community out there, because you want them to be part of the solution and you want them to actually contribute. So you provide a framework for them. That's what our project does, and it does quite well. With that, sometimes we get non-endorsements. So what the heck do you do with that? Because that's why you present it. It's a democracy, right? So this is where then you have to go in and you have to really negotiate out why. You might need to present a product suggestion to the vendor, or you might need to work in and say, no, this is a requirement, and you need to negotiate that through. But once you have those decisions and a pathway forward endorsed, find that your CWGs, they're brought on board, they feel consulted. They will be your best friends, even though there's been a robust discussion before that. But we do present that as significant change notices to our steering committee, so they're aware of what's coming, and that steering committee can then distribute that amongst their own health service networks and their staff. And so that's a bit about our clinical decision framework. Mentioned earlier that we have varied levels of adoption and digital literacy. Um, Look, most people, this will be familiar to most, but we do have multiple ways of, or we have multiple strategies around making sure that we can train users up. Now, we're having a big bang go live, folks, so that means I've got 6 weeks to train 4,500 users. It's not going to be the project that's doing that. The project will provide all the core materials out here. We need to corral all the support from all our 11 health services, and we actually need them to own some of this. So we provide them all the core materials, give them access to all the support tools here, and they own their implementation. So there's an implementation lead, there's an education lead at each of these health services, and we leverage that to drive out our change. And that also helps with adoption and sustaining that adoption. So once you have the sites already owning it, half your battle's done, because then the next half is then how they sustain it. And because there is that local knowledge and they've done it before with the Edition upgrade, as we do more and more upgrades, we hopefully use those same established mechanisms to drive the future changes through. We have role-specific learning pathways. We'll be managing a training environment too, and obviously putting everything that we have into the learning management system, which is shared across the region for us. We have our lovely SharePoint site. That is a big point. We point all users to that. It's just easier for us. We'll be doing flyers as we're doing a show reel as well coming up. So there's a lot of that stuff coming up. But at the moment, that's where we're at. And it's been well received so far, lots of FAQs. And when we have a Trak Edition mailbox. So as we do that, if we get a pattern, we see a pattern, we can stick them up in the FAQ section and guide people to that. And this will become more and more important, because as a lot more moving parts happen, we'll be able to provide them updates on this, and they can go to direct place here. Now, the middle one there is the clinical working groups. We actually provide all the recordings of these clinical working groups sessions in there, with the decisions recorded in the minutes. That shows that transparency that we have all the way out to the end users. So whilst that can seem a bit dangerous, it's worked so far for us. And they obviously do get a bit vetted from the project, just to make sure that individuals aren't individually identified in that sense. But we've got these mechanisms here with the SharePoint site, and other mechanisms to come. So what has worked? And this is my last slide, folks, so that's pretty good. What's worked for us is the engagement and ownership from the top down. I think when you saw my simple governance structure down there, the project control board, project steering committee, we've got executive support from the top down, and that has helped this project a lot. We've got clinicians involved in that, we've got management, we've got administrators as well. Having effective governance structures, so that governance structure, all the terms of references there have been agreed, and we do review them occasionally, and we make sure the memberships are always up to date. So for instance, we just recently appointed at the start of this year a CMIO into our project. So now it's time to start, how do we fold that role into the CMIO, into the project steering committee space? When we go to meds management, that's probably going to play a bit of a bigger factor. So we'll start reviewing it at that next point. You've seen about about the clinical decision framework I did present. So that's been a big winner for us. I heard testing being very important. I think it was actually, it's probably common for all implementation, but having a disciplined testing strategy is key. We raise iService tickets all the time, as the InterSystems team will know. I mean, we're in the hundreds. So, but we do have a strategy behind it. We do have reasons, and we do document to death the reasons for that. And as painful that is, it seems to be working. And we're down to about our last 50 or so items before we go into our UAT cycles here. I haven't been blessed with an experienced project team, and nobody's touching them either. So it's all clinically led, which is the beauty about this, and having the right people doing the right roles, that's been huge. And lastly, of course, we do partner with InterSystems. We've had a long-term relationship with them for 20 odd years, and it just keeps on growing strength to strength. So having that, and myself, really, what am I here for? I'm here as coach and umpire in this whole project. That's pretty much what a PM should do, really. If you do your job well, I think for me, as a project manager, being that coach and umpire to put the guardrails up around that. I'm not here to make decisions for this group. I've got clinicians and functional experts here that will do that. It's about putting the right group together, getting that diversity of opinion sorted out, having that transparency across the team. So that's been my role in this as well. So, and I'll just leave you with my last note is saying that these are change projects, guys. These are not technology projects for us. So once you understand that and you have that attitude in there, it kind of works. So.